Hey, welcome to Back Talk, the podcast for Successful Black Parenting Magazine, where we bring you insightful discussions on topics that matter the most to Black parents. I'm your host, Janice Robinson Celeste. Now, why are Black parents, and mainly Black pregnant women, dying in childbirth? Today, we're diving into the critical issue of maternal health for Black women. We'll talk about the challenges they face, what can be done for safer pregnancies, and how we can make a difference. So stay tuned.
This is Back Talk by Successful Black Parenting Magazine, the most listened to podcast for parents by parents.
Hello, everyone. Thank you for tuning into Back Talk by Successful Black Parenting Magazine, your go-to podcast talk show for parents. Now, I need a little favor from all of you fabulous listeners out there. Go ahead and spread the word about our show. We are live. That means you can post questions under this video and we could possibly answer it live on air, but do it early. Tell your friends, shout it out to your followers because, sharing is truly caring. And don't forget, use hashtag BackTalk when you post. Now, let's dive into today's show. Black women die at almost 3 times the rate of white women in childbirth. And a staggering 80% of these deaths are preventable. Now, today we have Dr. Yamicia Connor. I know I said your name wrong. I'm sorry, Yamicia. Well, she'll correct me when she gets on here. Connor, a Harvard-MIT-educated OB-GYN, who is leading the charge in addressing this crisis. We'll be discussing the alarming disparities in Black maternal health, the essential steps women can take to ensure safer pregnancies, and how we can work together to bring about meaningful change. Let's dive into this crucial discussion as I bring Dr. Connor to the stage. Welcome to the show, Dr. Connor. And please tell everyone how to say your name properly, and I apologize.
No problem. Well, thank you for having me. So my name is Dr. Yamicia Connor. And as stated, I'm an OB-GYN. I am also a mother of 3.
Awesome. Now, share a little bit more about your background and what inspired you to focus on maternal health, particularly for Black women.
So my journey into women's health was a little bit roundabout. I knew I always wanted to be a physician since I was very young. And I had planned on that, as I entered undergrad. I did my undergraduate work in chemical engineering and biology at MIT, and then went across the river to Harvard Medical School for my medical education. And at that time, I thought I was going to be a pediatric hematologist oncologist. And so that is a cancer doctor for kids. I did some work at St. Jude's and I loved working with children. I was very interested in cancer biology, so it all seemed to make sense. But like for so many medical students, you really don't know what you want to do until you enter the wards. And it was during my 3rd year that I discovered how much I enjoyed being in the operating room. And that's what made me look around for different options. I think what really drew me to women's health or OB-GYN is the ability to just provide so many different types of care to women. So there is, of course, the obstetrical care and the gynecological care, but there's also a lot of subspecialties like GYN oncology and urogynecology or reproductive endocrinology. So it's a really, it's a specialty with a deep depth and also a profound impact on women. And as I became a mother, this became even more important. My interest in Black maternal health specifically started when I was a resident. And as a Black physician, I saw firsthand the way that discrimination affected myself, but also my patients. And then that was further heightened by becoming a mom. And so now the risks that Black women face were not just this abstract thing, but these were risks that I myself were facing.
Right. Well, I mean, first of all, let's give you kudos because you're a Black physician. So we need more Black physicians as we need more Black teachers. This is important. It's really important, especially for our moms to be Now, the statistics on Black maternal and infant mortality are just alarming. They're absolutely alarming. I saw one statistic that said the most educated Black woman has a higher chance of dying in child birth than the lowest educated white woman. And then you might ask yourself, who's listening, why does that make a difference? Because we're not listened to. So we may have some knowledge about our health and about our bodies, but we're assumed to not know anything at all, at all. But the white woman who might not even have a high school diploma, she's looked at as, oh, she knows what she's talking about. But can you share some of the key data that highlights the disparities in maternal health outcomes for Black women? What do you know that we don't?
Right. So that is one thing I always like to remind people is the statistic that you just stated. And so to say it in a different way, Black mothers and Black babies, despite education and despite wealth, still have outcomes about equal to the poorest white women. And what that tells me, and I think it's something that we don't talk about enough, is although there's a lot of discussion about all the factors that go into maternal health outcomes, which is true. There are many things that go into having a healthy baby and a healthy mom. We like to focus on factors like lack of access to care and lack of compliance with doctor's instructions or poverty or, all the things that really allow the healthcare system to say, kind of not our problem. These are kind of bigger issues. But what that statistic really tells me is that's not true. You can't say that about this population of people. These women have resources. These women have, health insurance. These women have supportive partners. These women, have a level of education and are savvy. So what is it that is really driving these outcomes? And that's a question that I think our healthcare system has been really hesitant to answer. Other important statistics that I like to remind folks about, some of your viewers might have heard, Black women are 3 to 4 times more likely to die in pregnancy compared to their white counterparts. And although the absolute numbers are low, and so I don't want women to, run out in fear that, oh, I'm going to die in pregnancy. This is still a tremendous problem, and underlies just the overall, health inequities that exist inside of our entire system. When you compare this to women in peer countries, it is almost 9 times as likely. So really, really, devastating outcomes. As you stated at the top, 80% of these outcomes are preventable. And so that also tells me that we can be doing more as a health community in order to protect these women.
Right. So we think, okay, we've got our education, Black women, we're the largest, most educated group in the United States. That is statistically true. Now, we think we got our education, maybe we got our BMW, our Mercedes, our big house. Maybe we made it to that point, and we think that higher socioeconomic status protects us against poor health outcomes, right? But it's not true. And as you said, that it looks like basically, the healthcare system is blaming the victim, right? But we know that there have even been celebrities that we know, like, Beyonce, right? Then we had Serena Williams, who said she knew she was prone to blood clots. And she tried to tell them that she was having an episode where she knows that she has a blood clot situation. And no one on the floor listened to her while she had just delivered her baby. No one listened to her. And she had to go out to the nurse's desk and bang on the desk and say, listen to me, because they wouldn't even listen to her. And she's Serena Williams. So what chance do we have? We don't have anyone basically on our side. Why is it that women who are more affluent are now at high risk during pregnancy? Is it just that they're not listening to us? Because obviously it's not those other things that you talked about.
Well, I mean, the real tragedy is that we really don't know. We've had this data for quite a long time. It's more recently have been getting a lot of exposure, but we still don't really understand what is driving these outcomes. What my hypothesis is, and the hypothesis of my organization is that it's what's driving these outcomes falls into a bucket of medical racism. And so, to talk a little bit about how you should look at the data. So, there are kind of two big categories that I like to put the data into, right? So, one is, of course, we know that socioeconomic status, education, et cetera, affects pregnancy outcomes. Nobody is denying that. That is, and those issues, right? Probably the best way of addressing that problem is by these larger structural changes, like, for example, universal health care. But we're not just talking about the fact that women in America are dying at higher rates. We also know that Black women are dying at even higher rates, right? And so, what we need to make a distinction between is the inequities. So, for example, let's say we provided everyone universal insurance today. Black women will still be dying at higher rates. It would probably bring everyone's rate down, but Black women are still disproportionately affected. And so, we really have to think about what is causing that. And that's what I at least believe is driven by medical racism. And the area that we hope to focus in on is really around obstetrical emergencies. And our thoughts are, and our hypothesis, looking at the best data that we have available, is that women are presenting in extremis. And just as you stated before, they're not being listened to for some reason. And that standard of care is not being followed for some reason. And so the question is, how do we design an intervention that helps at that point in time? Because we believe that that's when you're going to have the maximal impact. A lot of the interventions right now that are going to addressing this problem is really addressing factors that are far upstream of the actual, what we think seminal event is. And so, could they have an impact? Yes. Would it have a direct or maximal impact? I just don't believe so.
I see. Wow. I mean, it's just amazing to me that it's not just this particular health issue. It seems that almost every health issue that we see coming out, we're always the one that's behind the eight ball, or the one that is likely to die, our children to adults. But I don't want to be that, grim reaper type of, negative Nancy right now. I want to try to keep it as positive as possible, but this needs to be talked about because something needs to be done about it. Let me ask you this, because we have some viewers that are on, I can see that are listening and watching right now. How can they be advocates to a pregnant woman? So say it's a mom like me and my daughter's having a baby, or I'm the husband or the significant other of a pregnant woman who might not be listened to at that moment. And my heart breaks because I'm thinking of that one dad in New York who lost his highly educated wife, and she had already had a son, and she told them that, she was having problems and she was bleeding internally. And they actually told him that they didn't have time for him right that moment. They didn't have time to deal with her, not knowing she was bleeding internally, but she was trying to tell them something. So how can we be advocates for the people we love while they're having a baby to make sure they're okay?
So I have a few thoughts on this. So the first is, you never want to go to the hospital by yourself. If you have the luxury of having someone who can support you, you always want to have a support person. Why that is important is, number one, when you are in crisis, it's very hard for you as the individual to advocate for yourself, because you may be sick. You might not be able to advocate for yourself. You might not be responsive. I mean, there's so many reasons why it's important to have another person in the room. Also, when you're getting a lot of information from doctors, that can be a really overwhelming time. And it's, just like, as they say, like two heads are better than one. It's important to have another set of eyes and ears, really observing and listening and taking in the information, so that you can, be best primed to, address whatever the issue is, if there's additional follow-up that's required. My second big thought is the work that we're doing at Giosada is really trying to address that point that you mentioned, right? Like, what do you do if you don't have anyone to advocate for you, or they're not listening to you? What do you do at that moment? And that's why we've designed our medical model to really hone in and provide patient support in real time. And so, best case scenario, we'll just provide resources, education, explain to you the things that the doctor might not have time to do, because I've been a busy practitioner. If it's in the middle of the night, you might be the only one available. You simply might not have the time to sit down and have an extended hour-long conversation with a patient. And so we hope to provide that education. But if we think that the standard of care is not being met, then we hope to intervene with actual medical recommendations, to help guide the care that you will receive, up to potential legal interventions if we think that people are being, particularly recalcitrant, or doing things that are very egregious. Now, I don't anticipate that is going to be the majority of practitioners. I think, when you go into medicine, you go in to help people, and most practitioners, I think, have very good intentions. And with a little bit of, potentially extra guidance, or being a bridge to improve communication, what have you, I think we're going to be able to try to address that situation, like you mentioned, like saying they don't have time for him, right? What he needed is an advocate in real time to say, no, you need to make time. This is an emergency, and this is why. And my belief is that most people will listen, but if they won't, there are also levers of power within the hospital infrastructure that you can pull if and when necessary, because we have to remember racism is a power construct. And so if we think that medical racism is what's driving these outcomes, then we need to give patients a power tool that they can use in real time in order to combat that factor that we think is really at the root cause of why some of these poor outcomes are happening.
Absolutely. So you would say it's definitely necessary that there's another component put in place for Black women who are giving birth, some support system. And if that's the case, tell us a little bit more about your organization.
So we're a very young organization. We're still in the startup phase, but what we're hoping to do is really focus in on that problem, right? Like, what is actually driving these poor outcomes? And to be very honest, we don't know. That data doesn't exist, but I'm very interested in seeing what happens when providers get into rooms with patients. Like, what is that experience? Like, what is happening? Because as a physician, I only know how I take care of patients, or how maybe the very limited group of other practitioners that I work with, how they take care of patients. But I don't know what's happening in the rooms with, patients writ large. And that data really doesn't exist either, right? And so I think it's going to be really important to gather that information to both design the most effective medical model for our organization, but also to try to disseminate that information more broadly, so that doctors, midwives, nurses can better take care of their Black patients and other patients of color.
All right. Now, but you have worked with many patients throughout your career. Can you share a story or two that illustrates like the challenges that Black women face during pregnancy and childbirth?
Unfortunately, there's so many, but there are a couple that really come to mind, and I want to highlight them because this is a very dangerous reproductive health landscape at the moment, and I want women to try to prepare themselves as much as possible. So the first is a patient that presented at around 15 weeks of pregnancy and broke her water and was subsequently sent home. And so why is that important? So number one, that pregnancy is no longer viable. Just full stop. That pregnancy will never develop, that the baby cannot form lungs without amniotic fluid. That baby cannot exist without outside of the mother's body. It's just simply too small, too young. And so the danger in sending a woman home in that sort of situation is the only possible outcomes are really poor outcomes for mom. So mom could get an infection, mom could start heavily bleeding, to the point that it's life threatening. And then also moms experience a lot of trauma, right, around that. And because of the restrictive abortion policies in North Carolina, there are much more restrictive policies further south and other places across the country. She was sent home because the baby still had a heartbeat, whereas the standard of care would dictate, even if you're not going to do a termination, that woman should have been admitted to the hospital for observation, and so that we can be present if if those outcomes do happen, and at the very least potentially starting antibiotics. Although this landscape is so new, we don't really have a lot of data to substantiate what you should do, because the way that we're all have been trained is that pregnancy is not viable. She needs a termination. And so anything you do after that is really, we're in new landscape altogether, right? And so she can't comes back. Eventually, I take her to the operating room because she had the miscarriage, but the placenta was still very vascularized. And the placenta, when you have miscarriages around that point in pregnancy, very often the placenta will get stuck. It won't come out. And she lost 2 liters of blood. She had to be admitted to the ICU and transferred to a bigger hospital. Now she is fine. She is alive. She is well. But so many other things could have happened, right? She could have had a severe infection. There was a time when she was bleeding so heavily, and people who don't practice in this space, they don't quite understand that, because even the other practitioners who aren't always working with pregnant women, they'd never seen bleeding that rapid, that quickly from a patient. People were scared, honestly, in the operating room. Because I've seen this before, because we were prepared, we were able to manage it. But women can bleed heavily very quickly. We're talking about in minutes. You can lose, lots and lots and lots of blood. And so I just want to highlight for women that this could be very dangerous and really life threatening. And that's just one simple example. I have like so many other stories, unfortunately.
I understand. And, I hear these stories, and I, of course, can't help but think of my own stories. And I've shared this on this podcast that when I had my first daughter, first of all, I did have a lot of bleeding. I remember my husband at the time saying that it looked like a murder scene. Like it was so much blood just on the floor and on the gurney thing I was on when I first arrived at the hospital. But I was yelled at by the doctor because I was so small. I had such a small stature that even though I was to term, I didn't look that pregnant. And he just yelled at me saying this baby's going to be small, and just assumed because I was a young Black mother that I wasn't doing what I was supposed to do,
Well,
when it was just the opposite. I was doing everything, looking up stuff to do. And
right.
when my daughter was born, she was 7 pounds, 11 ounces that day. So
That's
he
a good
came
size.
he came in with a very sorry, like apologizing to me. But I couldn't even say anything to him when he was yelling at me. First, I was in shock. I couldn't say anything. That's a different me back then. Okay. And then he came and apologized. And I was just so traumatized by it all that I couldn't even say anything at that point. And luckily I made it through to have 2 more children, but what we go through as moms during the time we have having our baby should be a beautiful moment. And most times it is, but then you have these instances where your doctor or whoever it is, for me, I was going to a healthcare clinic. So I didn't know who my doctor was going to be. I didn't know this man. might yell at you or even just not care for you properly. So one of the things that I tell our listeners is to be very loud. This is your time to be loud. If you're the husband and you know something's wrong with your wife or girlfriend or significant other, whatever it is, you need to be loud and go to the nurse's desk like Serena Williams, bang on it, risk getting kicked out if necessary to get someone's attention, because it's life or death, and it's possibly life or death. We don't know until they actually check the mom out. So you emphasize the importance of women educating themselves about pregnancy care, and I want to know, we kind of talked about a little bit, but what are the top things pregnant women and their partners should know to advocate for their health?
So I always tell my patients there are a couple top warning signs I like to tell them. These are always reasons to give me a call, give the office a call, or present to care. So the first is bleeding. If you are bleeding heavily in pregnancy, and at the beginning of, towards the end of pregnancy, if you're bleeding even a little bit, that's something that I want you to give me a phone call about. And I can help you assess whether do you need to come in for an evaluation, or, do you need an ultrasound? Do you need to follow up in clinic, etc.? The second thing is losing fluid. So anytime a patient is leaking, or they feel like they're losing urine, or their discharge is really heavy all of a sudden, what I get concerned about is, did they break their water? And so that is an emergency until otherwise ruled out. The third thing is intense abdominal pain, particularly if it is before the baby's due date. So if the baby is preterm, because again, if we are in preterm labor, that's something that we want to evaluate you for. We want to monitor you for. We want you into the hospital. And then the last thing is decreased fetal movement. If the baby is not moving normally, then that is something that we would want to know. Babies, after everyone starts to feel movement at slightly different times. If you've had a baby before, you might feel it a little bit earlier. But once you start feeling movement of your baby, it shouldn't stop until that baby is born, right? You should still continuously feel the baby move every single day. So if you're going an entire day without feeling the baby move, that's not normal. If the baby is moving, but just not moving just quite right, you get to know your baby by, I'll give an example. My most recent pregnancy, my son was very active. Like, he moved all the time. My other two were not that active. And so you get to know what's normal. And so if you're off your normal, that's a reason to give me a call.
Absolutely. Now, what about prenatal tests? Now, what critical prenatal tests and screenings every pregnant woman should have? But what about Black women? Is there anything, special we should do, or that we can protect ourselves, starting with the prenatal assessments?
So I don't think there's anything in particular that Black women need to do differently. We just need to make sure that we're receiving the care that we should be receiving. And so things that every pregnancy should be offered is, number one, genetic testing. And so there's two types of genetics testing. There's, carrier screening, meaning looking at mom and dad to see if they are carriers of any recessive traits that could then be seen in the baby. And that could be done before you're even pregnant. If you have, a known partner, and this is the partner that you are planning pregnancy with, you can go ahead and do that testing when you have preconception counseling. Okay. There's a second type of genetic testing that's actually testing the baby itself. And the way that we do this, we don't test the baby, right? We have kind of workarounds. We draw blood from mom, and we look for different things to give us some indication if there are any abnormalities that we can assess in the baby. And the thing that we're really looking for are trisomies. The most common one is that people know is trisomy 21. That's Down syndrome, but there are also others that we're looking for. More and more, that testing is getting more sophisticated, and we're able to deduce more information. But that is kind of a must be offered, at least to patients. Not everyone has to accept it, but should be offered. The second thing is a fetal screening. So this is having a detailed fetal survey around 16 to 20 weeks. This allows the doctor to look at all the baby's organs and make sure anatomically things are developing normally. The next thing I always counsel my patients about are diabetes testing. Depending on your risk factors, this can happen either once or twice in pregnancy. It can happen around 28 weeks, or if you're at high risk, can happen at the beginning of pregnancy. And then even if you don't test for diabetes, will happen again in the third trimester. And then the last is GBS screening. So this is looking for a naturally occurring bacteria in the vaginas of mom. Doesn't make mom sick at all, but it can make babies very sick, particularly if the baby is born preterm. Those are all things that should be offered to every pregnant woman.
Wow, that's so much more than what I went through. All I remember is a few ultrasounds, so and maybe some blood tests. I don't remember all of this, but that's pretty awesome that you said all that. So I hope people are taking notes that are listening out there. In addition, I want to remind you that you can ask questions live if you're on our YouTube channel or our Facebook page. Just type it right underneath in the comments, and I will see it. It takes a while to pop up here, and you can ask a question. I'll put it up live. We have about 15 minutes or so to go, so you still have time. Now, I remember reading something about the difference in care between like big teaching hospitals and rural hospitals. So if a mom isn't in an urban setting with a big hospital, like how do you advocate for better care there? Is there a difference?
So there is a big difference. And unfortunately, the number of what we call like maternal deserts is only increasing as a lot of hospitals in rural communities are closing. And, this was honestly not something that I fully appreciated until moving to North Carolina and starting to practice in a rural setting, because like so many physicians out there, we train in these big teaching hospitals. Because those are the hospitals that see the sickest patients, largest communities, you have the largest amount of doctors. So it makes sense. But what it doesn't do is expose you to how most patients are cared for in this country, which is in much smaller hospitals. And so the big difference that I have seen really are in the resource expectation. I have found excellent doctors in both big hospitals and and smaller hospitals. But the type of care that you're able to provide depends on just more than how good you are as a doctor, because you need an ecosystem to take care of particularly high risk patients. And so, what do I mean by that ecosystem? So, if I have a complication, for example, with a high risk patient, if I'm in a big teaching hospital, then I'm able to call in some help, right? I'm able to call some of my colleagues who might be subspecialists in a different area. For example, if I think that they have a urological injury, I can call in a urologist. If I feel like they're having more an obstetrical complication, I can call in a high risk obstetrician. I can call in other medical doctors if I think that they're having a heart issue. That is not always available at smaller hospitals. And so most of the time people really honestly don't have a choice where they go. A lot of where you're going to go is going to depend on where you are geographically located. But what you can and should do is to talk to your provider and ask them, I understand I might have a low risk pregnancy. Let's say a complication were to happen. What is your protocol for that? Because we all have plans. And if your doctor doesn't really have a plan, that should be a warning sign. And so, for example, in the hospitals that I practice, the bigger teaching hospitals here are in the like triangle area. So UNC has a very big hospital system. Duke is the other big hospital system. There are also others, Wake Med, et cetera. And so that's typically what our plan is. We will stabilize the patient and then transfer them to a bigger hospital if we feel like we cannot provide the standard of care that they require. But sometimes that decision making is often at the discretion of the doctor. And for some doctors, they might hesitate to make that transfer when it is appropriate to do so. And so again, that's something that you want to be cognizant about. If you feel like something just isn't right, we are not getting the care that we need to, you always, as a patient, have the right to request a transfer to another hospital system. And if you are stable, they are obligated to try to make that happen for you.
That's great advice. I would have never known that. So I'm in the hospital. I'm having a bad experience with my doctor. I can ask for a transfer to another hospital of my choice,
Exactly.
or actually, oh wow, okay. Because I'm
Mhm.
afraid they might send me to a hospital that doesn't have a great reputation. So that's great to
Mhm.
know. All right, so you guys hear that, right? So now I'm wondering, are we as moms to be, I'm not trying to put that on me, but as moms to be, are we safer doing like home births, like with midwives? Or I've heard of moms having their babies in the back of an Uber. Like, what is safe now?
So there's a lot of debate in this area, but I tend to be a more conservative practitioner, and so I would not recommend a home birth to my patient.
Mhm.
I would not do a home birth myself, and I wouldn't recommend it to anyone. I understand the desire and why women are moving towards that option because they feel they're not being listened to. They feel like they're not being respected. They feel like they might be able to get better care. What I would say to those women is let's see if we can find something in the middle. And so there are birthing centers that are in really close proximity to a hospital. That might be a good option for you if you desire that, home birth experience, the less hospital, the less medicalized, birthing, process. But that also will keep you safe because the hospital is close by. What you don't want to happen is to be in a true emergency because sometimes minutes make the difference between, a very poor outcome and just an emergency that can be managed. You don't want to be, 45 minutes away from the closest hospital. I would never want that to happen. Um, Particularly one for my safety, but also for the safety of the baby, because let's say even full term babies can come out, with some respiratory depression. And in a big hospital or in any hospital, that's typically something we can manage right there in the room. And most babies are able to kind of bounce right back. But if you don't have that resource, you can take an otherwise healthy baby that could be, significantly compromised because they weren't able to be appropriately resuscitated, and that is a real tragedy for the women that happens to.
I see. Well, looking forward, what changes do you hope to see in maternal health care, especially for Black women?
Yeah, actually, this is a this is a hard question for me to answer because um, the reproductive landscape, as I mentioned earlier, in this country is evolving in a way that is going to make pregnancy more dangerous, just full stop. And so, what I want to empower women, empower themselves, but also share this information with all the women that you know in your life, with all the people that you know in your life. We need to educate ourselves about why, like, what can happen in a pregnancy and what we are going to do if an emergency were to happen and we cannot get the care that we feel like we need. That should be a plan that is a part of, honestly, preconception counseling and pregnancy planning. Particularly if you're in a state that has really restrictive, again, abortion practices. I don't even like to say, I don't necessarily even like to classify as, abortion, because some of these are just medically indicated termination of pregnancies that are not viable. And to me, that's not what people typically think about as an abortion. But now they've all been lumped in together in a way that makes pregnancy potentially really unsafe. And so I advise women to have a plan and also talk to your doctor about, what are my options in this state? If this were to happen, what do I do? What are your thoughts? Do you have any advice? And finding doctors who are thinking about this. Because if they're not thinking about it, in my opinion, you're really doing your patients a disservice.
Absolutely. Now, you said this landscape of childbirth is going to get more dangerous. What do you mean by that?
So, what many of us haven't recognize, and I'll be honest, I didn't actually fully appreciate, even as a physician in this space, is that the 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 work that Roe was doing in protecting all of us in pregnancy. It was making it so that these now very complicated management decisions that used to be made between doctors and patients now are being made by third parties, that honestly don't have the medical background to really be weighing in. Let's take elective abortions off the table for right now. It's a different discussion. But even in emergency situations, women are finding themselves that they are not able to access the care that they need. And if you cannot access this care, that for some fraction of women is going to be life threatening. It's just the reality. And what we anticipate is, as these restrictions get more widespread, particularly in entire geographies, so that people are no longer able to really travel easily to like the next state, that's going to affect outcomes. And of course, whenever there is something that is affects health negatively, Black women are going to be the worst hit. It's just something that we know.
Right. And we're used to, unfortunately. So basically, politicians are making decisions about our bodies that put us in more precarious situations as pregnant women. And most of these politicians that I've seen, no, they're not even qualified to flip pancakes. So to make decisions about our bodies, I think that's a bit much, and too much into our personal space. But thank you for sharing that, because I wasn't putting that together with how dangerous it could be for pregnant women. Because Roe versus Wade, we know that our rights were taken away, but to think of the dangers that they put women in is something else. Now,
Exactly.
how can we help? Like, our listeners are here. We have several people on this podcast watching today. What can they do to contribute to this movement for equity?
I think the first thing that we can do is get educated and start joining communities or supporting others who are trying to spread the word. We are just one of many organizations that is trying to do this work, but unfortunately, because of the years of neglect in this space, um, there's so much work to be done. Um, the other additional thing is, Black women and issues that Black women face are never well funded. And so we're kind of dealing with like two problems. One is there's so much work that is left undone, and we are working and struggling, to get the resources in order to do that work. And so the best thing that we can do for each other is really support one another, educate all the women in your life, vote. Vote like your life depends on it, because for some of us it will.
Mhm.
And then support organizations that are trying to make pregnancy care safer for everyone. Because when pregnancy is safe for everyone, it will be safe for Black women. And that's one thing that we have to kind of drill down into our allies, right? The reason that this matters is because and that's what we have learned with Roe, when you do not protect the most vulnerable amongst us, all of us will suffer. And that's been at least one of the lessons from Roe, because in people's mind, they thought that this was affecting, maybe a young, most likely Black, irresponsible woman who's using, abortion care for like birth control, which in my opinion, that's nobody. I've never met that person. But that's like the caricature people will have in mind, when in reality, this right was protecting all of us, and was doing like the heavy lifting that we didn't even have to think about. What if I break my water at 15 weeks? Now that's something that you do have to think about and talk about with your doctor about what your plan will be.
It's incredible to think about, actually. And when people tell me, I don't do politics, I don't vote, I'm like, well, politics will do you if you don't, because they are watching you because they want to make sure they have control over you. So
Yeah.
the only little bit of control we have are individual votes that can add up. So don't sit here and say you don't vote. Go out and get registered to vote because
Yeah.
every vote does count. It might not go in your favor every time, but it's like a gamble, right? So you got to try. Now,
Yeah.
before we wrap up, what message do you have for pregnant women and their partners who might be listening and feeling anxious about their pregnancies?
I want to remind everyone that pregnancy is joyful. We emphasize the stressful parts because we want to protect people, and that's my job. My job is to think about all the ways that things can go wrong, so that you don't have to do that work. But by and large, most pregnancy, thank God, um, are healthy, and women go on to have healthy, happy babies. But for some fraction of us, we are going to face obstacles, and we need to make sure that we have a health system and providers who are able and willing to help all women manage those challenges.
Fantastic. Now, finally, where can our listeners learn more about your work and connect with you for more resources and support?
Absolutely. So to learn more about what we're doing at Diosara, you can visit our website. That is www.diosara.com. Or you can go to my personal website. It's just my first and last name.com. And that will link you to two organizations, a nonprofit, and Diosara, which is the women's health company. And either way you go, you can kind of get back to us to find out more information. And then we also have a couple of giveaways for your listeners that provide some key facts of things, of the America's maternal mortality crisis, that we want women to be aware of. And it provides our contact information, as well as a snapshot of the book that we're writing, which is going to be focused on pregnancy care, really centering Black women. This is something that we're really proud about. We hope to have done in the next several months. And it's just one small thing that we hope to contribute to try to make pregnancy experiences for Black women safer and more joyful.
Oh, that's great. You're coming out with a book. You know what? We're going to put those websites underneath our video description. And we will also have a download for those handouts that you graciously provided, where you can just download them yourself from our website. We're putting together for next week. You can look for an article about this very thing because we had Maternal Mental Health Month. We're going to kind of put things together and some of the videos together as well, and you will be able to get those handouts that Dr. Connor just spoke about. Well, Dr. Connor, I want to thank you for joining us today.
It's my pleasure.
It's a pleasure for us too. Stay tuned after, and I'll tell you how to get the video. But for everybody else out there, big shout out to you all for tuning in and engaging with us here at Back Talk and Successful Black Parenting Magazine, the syndicated podcast for parents. And if you're interested in advertising on our podcast or on our website, it's as low as $60 for a paid post and $300 for a banner on our homepage. Podcast ads are even cheaper, 30 seconds for $30. Contact me at successfulblackparenting.com for more information, and make sure you follow us on social media. The more you engage, the more we all can thrive. Well, we'll be back next week with more. Until next time, I wish you all the best and much success. Take care. Thanks for listening, everyone.